A very warm welcome to the second of the recall series for the year 2025, and this time it's November INI-CET. November INI-CET results have been declared a couple of days back, and it's basically been an exam that has not mirrored the May exam. Generally, over the years, ever since INI-CET has been introduced, we've seen the November exam tends to mirror the May exam quite a lot, but this time it was not so. And that's exactly the reason why you can see that the topper who scored rank 1 has come out with 162 right out of 200, and by scoring about 150 right out of 200, you are in the first 100. So that means that the competition over there is much less, primarily because of the reason that simple straightforward questions constituted only 120 out of 200, if I'm right, approximately. We had remaining 60 questions or so which were pretty much correlation integration type, and 20 questions or so which were in the tough category. So unless and until you break into that correlation integration zone, you are not going to find yourself inside the first 10,000, because 118, 119 right is somewhere where the 10,000 ranker finds himself. So it's not about recall, but it's rather about placement. That's why I think this exam is all about the dynamics between recall and placement, because there's a lot of difference between recalling and placing. Now, when you talk of recall, I think all of you are basically fond of this word called recall, wherein there is something written in that page of your notebook. You are trying to take your brain to that particular page in your notebook where that statement about this particular topic has been written. When you are able to recall from there, you're pretty happy with that source, and then you mark the answer. And you feel that it's your learning lacunae that you cannot recall all the 200 questions. But primarily, nobody, how much ever brilliant you are, will be able to recall everything, because it is not about recall. There are only 60% questions in this exam, and for that matter, any exam for that matter you take, you will be able to recall an answer maybe 50 to 60%, depending upon the difficulty level of the exam. The remaining questions are all about placement, and placement is about where you place the question, what is your understanding of that particular zone or scenario or topic or disease condition, and with that understanding, how are you able to eliminate the other options and come to the answer. So this difference in dynamics between recall and placement is exactly what this whole discussion is about. I'm trying to actually, in my effort probably in this recall, is to try and help you to place the disease in their pockets. That's what we always say. That means if you are able to place that scenario in particular one particular area, and you have knowledge around that zone, you have some knowledge around that zone, you will be able to easily answer, rather than trying to look for from where did I study this, where did I study this, in which page of my book does it come, and am I trying to recall. That's more 10 standard type. I think it's time we grow from there, and rather try to place the disease in the pocket, and from there try to decipher the answers and bank on our elimination skills, because that is the only thing that can actually take us to the top of the ladder. So on that note, we're starting off with the exam. This is a Japanese code, although Japanese are not that aggressive, I personally believe. It's more of an Aussie kind of a code, but this is pretty much Japanese. So you are essentially having to take the bull by its horns. There is no other option, because it's such a competitive scenario. If you've gone to some of the popular offline classes now, you'll see the level of competition. When you sit at home and study online, you may not actually kind of be able to put it into your system. But if once you start going to one or two classes here and there, you will know the degree of toughness. This is a make or break exam. And let us be very clear about it, not exaggerating or anything. And this is a rate limiting exam also, because if you want to end up with good teams and if you want to be part of some good institutions, you have to actually get a good rank over here. There is no other option. Once again, you get an average rank. Once again, you get to a mediocre college. Once again, you go behind your passion, which is your subject, and which is definitely justified also. Then again, you are having to run a race where somebody else is way ahead of you, and you are again having to do the catching up thing. And this is not 18 years or 19 years to do catching up stuff. We are all grown up adults, so we need to actually make a very important, impactful performance here, so that helps, that actually holds us in good stead going forward. So that's why there is no way out rather than to take the bull by its horns. When the going gets tough, the tough has to get going. There is no other option. So a few 2-3 words about the exam. As I said, this is not a mirror image of May. This is a totally different exam. Very dicey exam, like the weather here now. It may rain, may not rain kind of stuff. So most of the questions are very dicey. You can't call them tough. You can't call them easy. It is kind of somewhere in the middle where your correlation integration, I think, comes in handy. And that's why placing the disease in the pocket. If you are able to place the disease in the right pocket, with your given knowledge, you can eliminate and come to the answer. And there is nothing called medicine questions here. It's almost like full correlation integration. That means physiology, patho. So many things are actually involved. And as I'm telling you, it's not the weight, but the muscle mass. We often look into the weight and BMI and talk keep talking a lot about reducing weight and BMI. So if you starve also, you can actually reduce your weight, but then you're losing your muscle. So basically it's a muscle that matters. So here also core concepts that matters, and understand, correlate, integrate, eliminate. This is what it is. So I am focusing on the single key term, that is to understand the soul of the topic, correlate it with everything else possible, integrate it with the other subjects, and then try and eliminate our way to success, rather than trying to study the whole thing, which is not practical, rather than going for shortcuts again, where we'll answer those 120 questions, find ourselves happy, but not get any good rank. So rather than that, let us be straight. Let us go and take the bull by its horns. As I said, we have nothing to lose here. We have everything to play for. So I think all of you are in that mindset also. Majority of you are like not working, you are completely into the zone, you know that this is such an important exam, and 100% justified as well, because to kickstart your career at this point, you need a good rank in this exam, and that goes without saying. So you have to get your career rolling, and for that this is mandatory. So on that note, let us go to the chapters. As usual, I've tried to go for some kind of a subject arrangement, but many times failed, okay, because the questions are not even that way. You can't put it in one subject. Let us start off with endocrinology and metabolism as usual. Question number one, which the following is not seen in constant syndrome. So what's the understanding? Simple understanding. I'm not going to any textbook quotes, references, nothing. We're not using anything here. What's the understanding? Cons is an example of PHA. So if you put it in this chapter, that itself settles it. This is primary hyperaldosteronism. Primary hyperaldosteronism is mostly because of a bilateral adrenal hyperplasia, which is the most commonest cause. And the second most commonest cause is a unilateral adenoma. So unilateral adenoma, which produces aldosterone, is basically the second most commonest cause. And this unilateral adenoma is what we call as Cons syndrome. So what is the issue here? The issue is aldosterone is in excess. When you know that aldosterone is in excess, you should be able to go back to this P cell of your cortical collecting duct. In this P cell of the cortical collecting duct, if this is the apical membrane and this is the basolateral membrane, aldosterone has got its receptor inside the basolateral membrane and inside the cytoplasm, not on the membrane. And once aldosterone comes and binds to the receptor, there is induction of aldosterone induced proteins over here. They will activate the epithelial sodium channel, and there are potassium or H plus channels through which potassium or H plus goes out. These epithelial sodium channels will take in salt and water. They will take in salt and water. Because they take in salt and water, you have what is called as hypertension here. Because you have potassium being driven out, you have hypokalemia here. Because you have H plus being driven out, you have alkalosis here. That's why it's an example of hypertension, hypokalemia, alkalosis. So this is basically how the whole thing works. So it's very, very simple. Now let's see the options. Hypertension, hypokalemia, alkalosis is there. And the wrong option given here is hypernatremia. So even if you don't know anything about this, you know to get hypernatremia practically in a common person with any disease for that matter, it's not possible. Because for you to get hypernatremia, one, you shouldn't be in a position to drink water, because as long as you drink, you will not get hypernatremia. Second is that your ADH should be cut off. So ADH cut off and not able to drink water means it is a person who is in the neurosurgery ICU. Apart from that, to get hypernatremia is very, very, very rare. Though in geriatric patients and all, you can get, but very rare otherwise. So this question, there is nothing much to think about. It is hypertension, hypokalemia, alkalosis. Okay, so very much a basic kind of a question. But again, I'm trying to tell you, if you know this roadmap, if you know the soul, if you know the crux, with this, you can keep answering. So what else will have hypertension, hypokalemia, alkalosis? Again, cons, littles will have hypertension, hypokalemia, alkalosis. If aldosterone is not there, what will happen? So you get adenosine where aldosterone is not there. If there is aldosterone resistance, what will happen? Then you can start talking about renal tubular acidosis 4 and stuff. So we can correlate and go. But the thing is, the base understanding has to be perfect. Okay. Question number 2. 38-year-old female presents with buffalo hump moon facies abdominal striae. So you know that we're dealing with a Cushing syndrome. She is a known case of SLE on treatment with steroid means you know that this is exogenous Cushing syndrome. What is the best test for investigation? So exogenous Cushing syndrome means the moment you take more than 7.5 milligram per day of steroid for more than or equal to 3 weeks, your axis is going to be cut off. The moment your axis is going to be cut off, ACTH is going to get depressed. When ACTH is depressed, what will happen? You will not be having any endogenous cortisol. That's the reason why after COVID, we had a lot of patients with secondary adrenal insufficiency, because we gave them steroid and did not taper properly and stopped it off. So they all started getting adrenal insufficiency. So the moment you keep on taking steroid and stop it abruptly, you will be having axis insufficiency, or your cortisol will touch rock bottom. That's why when I talked about evaluation of Cushing, we've always stressed on the fact that no, you give the patient, you admit the patient on that day, you take the blood at night without the patient himself or herself knowing. Next day morning also you take blood, and when you take blood at night and when you take blood in the morning, you will know 2-3 very, very important things. Morning you take blood and you find out that the fasting cortisol is rock bottom, means you know it is exogenous. Between the 11 p.m. and the morning sample, if there is so much of variation, you know that there is loss of the rhythm rhythm. So all these things we have actually said. So this is the exogenous question for which no high-funded tests like LDST, ODDST, high-dose DEXA, nothing is required. Just cortisol and ACTH levels, more than enough. The moment you take steroids in excess of more than 7.5 for 3 weeks or more, your axis is going to get suppressed. ACTH is going to be low. Cortisol is going to touch rock bottom undetectable. Anything hyphened about this? Nothing hyphened about this. Just basic understanding is enough. People have gone and written all the tests for this answer. It's just because their understanding is not good. It's not got anything else. It has not got to do with anything else. Statements may below mention about the anion gap in different conditions. Again, we have had extensive discussions on this. Ketoacidosis is one condition where we'll be having increase in anion gap. All of you know that, which can be diabetic ketoacidosis, alcoholic ketoacidosis, or starvation ketoacidosis. Uremic acidosis, all of you know, will be having increase in anion gap. Salicylate poisoning will have increase in anion gap. Methanol will be always having increase in anion gap. So methanol, ethanol, ethylene glycol, all these things will be having increase in anion gap. Lactic acidosis will be having increase in anion gap. So all these are the causes for increase in anion gap. And as we have said, total cations is equal to total anions in the body. Measured cations plus unmeasured cations is equal to measured anions plus unmeasured anions in the body. Measured cation minus measured anion is equal to unmeasured anion minus unmeasured cation. Measured cation is your sodium. Measured anions are chloride and bicarbonate. That is equal to unmeasured anion minus unmeasured cation. So anion gap is equal to unmeasured anion minus unmeasured cation. The moment unmeasured anions increase, your anion gap increases. And the unmeasured anions can be keto acids, uremic acids, it can be alcohol, it can be lactic acid, and all this stuff. Okay, so starvation acidosis, diabetic ketoacidosis, vomiting is all about metabolic alkalosis. So it's all about metabolic alkalosis. It's a very basic question. All of you have got it right. But this is the base. You can expand on this base how much ever you want. So I have again tried to bring in all the major players over here. Beta hydroxybutyric acid, uremic acids, aspirin, methanol, lactate, chronic acetaminophen use even, and glycols, which includes ethylene glycol, diethylene glycol, all those things basically. Okay, so that's it. There are so many mnemonics, so many different types of mnemonics. So this is what it is. Then OGTT plotting is basically a question where they have tried to test whether you know the criteria for diabetes. So what's the criteria for diabetes? Everybody knows the criteria for diabetes. HbA1c more than or equal to 6.5% is one criteria, or your fasting plasma glucose is more than or equal to 126 milligram per deciliter is another criteria, or your 2-hour ppbs is more than or equal to 200 milligram per deciliter is another criteria, or you are having a random blood sugar more than or equal to 200 milligram per deciliter plus symptoms. Okay, so polydipsia, polyuria, polyphagia we used to say previously. Now we say polydipsia, polyuria, weight loss. Polyphagia has been replaced by weight loss. So this is what it is. So you can see here, 2-hour cutoff, wherever it is about 200, that is actually equal to diabetes. So you can see 1 and 2 is basically equal to diabetes. Here fasting, everything is under 126, so that is not equal to diabetes. So you can say 1 and 2 is basically equal to diabetes. Simple question, just trying to check whether you know the definition. This again, most people got it right. There's nothing confusing with this. That is about the adult medicine part. Got 2 pediatric questions here, which some of the people did get wrong, but this is based on a previous year question. So I think you can answer it that way. So this is a clear case of DK that they have mentioned. So there is acidosis, there is high blood sugars, and you know that you are dealing with the DK. And in DK, you know that you have to give insulin, you have to give fluids, and you have to replace potassium. The only question is what many people don't know is about how to replace in a child. So adult, we have actually discussed in detail about replacement, but I haven't taught about how to replace in a child. But again, if you look at it, 10-year-old child means you take roughly age will be how much? 7a minus 5 by 2. So you take 70 minus 5, 65 by 2, roughly say 37, 38 kgs, or you take roughly 40 kg weight in the child. So 40 kg weight in the child, I have told you on an average 9 liters to 12 liters is the fluid deficit. You can say 9 liters is roughly the fluid deficit. So if you want to reach 9-liter fluid deficit, then probably you may require what? You may require very, very aggressive correction, right? You may require very, very aggressive correction. So 10 ml per kg NS over 20 minutes means that will come to only 400 ml, right? 400 ml. So when you see the patient itself, you are starting 2 lines and you are giving 2 pints and 1 pint NS through this line, 1 pint NS through the other line. So basically you may require 20 ml per kilogram to reach what? 20 ml per kilogram to reach at least 800 to 900 ml. So with that logic, you should be able to say that it is 20 ml per kilogram. And are we using RL, NS or half NS? We are always using NS. So we are always using NS. So 20 ml per kilogram NS over 20 minutes, followed by insulin infusion and KCl 40 milliequivalents per liter. KCl 40 milliequivalents per liter is like, we have 1 ampule KCl, which is basically equal to 10 ml. 1 ml is equal to 2 milliequivalents. So we are having 20 milliequivalents of potassium in that 1 ampule of potassium chloride. So how much you give is basically dependent on center to center. So we generally give 1 ampule for every 2 pi NS. So like that way, 20 milliequivalents per liter is also more than okay. But even if you give 40 milliequivalents per liter, depending upon your rate of infusion, you can actually correct it. So that way, if you look at this question, this is pretty much okay. This is pretty much the correct answer. But again, there can be debates. There can be so many ways of managing. I will still go with this as the best answer among whatever I have. Obviously, this is wrong. 10 ml per kilogram is also wrong. 7% of deficit correction is not enough. 10% of deficit correction is enough. And potassium chloride, I would have basically not gone for that much of a correction, especially when the patient has a potassium which is 4.8. That much of a correction is not generally required. But out of the given options, this is the best answer. Okay, Nobel Prize for Physiology and Medicine. I think this is something which I mean, in groups and so many places where we are active, we have shared this quite a lot about tolerance and discussed this in detail. But unfortunately, the prizes were released after we shot for the app. So I don't know whether this is something which you are aware of. But I mean, if you are active in some of the groups where medicine is being discussed, I think right as soon as the prizes were given, I think everybody has talked in length and breadth about it. Parathormone is increased in. Very, very simple, straightforward question. Where do you have hypercalcemia? I told you have parathormone dependent, parathormone independent. The moment you are having parathormone dependent, then it is a parathyroid adenoma or a parathyroid hyperplasia or a parathyroid carcinoma. Okay. But very importantly, two more things I told you. One is lithium, which can produce parathyroid dependent hypercalcemia. Second, I told you is a condition called familial hypocalciuric hypercalcemia. In the workup of hypercalcemia, when your parathormone and calcium levels are high, you expect the urinary calcium to be high. The only condition where urinary calcium is low but blood calcium is high is your hypocalciuric hypercalcemia. This is due to loss of function mutation of which receptor? Familial hypocalciuric hypercalcemia is due to loss of function mutation of your calcium sensing receptor, which is in the thickening loop of leukophile. That is why PTH dependent hypercalcemia is what you are checking out for here. And PTH dependent hypercalcemia is parathyroid adenoma, hyperplasia, carcinoma, FHH, lithium. This we have stressed on, stressed on, stressed on. So that understanding, when calcium is high, because you already know calcium is a PYQ. Okay, PYT. It's a PYT. It's a big PYT. Hypocalcemic calcium is a big time PYT. So when you know that it is a big time PYT, automatically you have to know everything around calcium. So that way this question can be answered. So as far as the endocrine questions are concerned, I don't think there is much of an issue. This is a tough question. Which of the following is correct about Findranon? Because Findranon, is an aldosterone antagonist. Okay, so we have aldosterone antagonists which form the backbone of treating so many conditions, especially heart failure, because we have the Fantastic Four in heart failure. So the Fantastic Four in heart failure, ARNI is there, beta blockers are there. Then comes the aldosterone antagonist. So ARNI, beta blockers, SGLT2 antagonist, and your aldosterone antagonist form the Fantastic Four. So here you have aldosterone antagonists. Under this aldosterone antagonist, the newer ones are the non-steroidal ones. So non-steroidal aldosterone antagonists with very less endocrine side effects. So non-steroidal aldosterone antagonist with less endocrine side effects is what we actually call as your Findranon. This is what we actually call as Findranon, and we have discussed Findranon in a lot of places. Especially for me, practically, I have discussed this in two places. One is heart failure management. Second is proteinuria reduction in diabetic patients. Diabetic patients, proteinuria reduction, ACE or ARB is first line, SGLT2 inhibitors, and then Findranon. These are the three drugs. So let us see. It causes a significant reduction in blood pressure. Never ever does it cause any significant reduction in blood pressure. It is not given for treatment of hypertension at any point. It causes a very minimal dip in BP only. So anyway, whatever is there with 4, you can strike it off. Then it has a cardioprotective effect. Yes, 100% it has a cardioprotective effect. That is why it is one among the 4 fantastic drugs for fantastic heart failure. Fantastic for heart failure. It causes less hyperkalemia than spironolactone. Yeah. So both are actually producing hyperkalemia as a major side effect. But if you see for the difference, then you know that, okay, this produces less hyperkalemia than spironolactone. It gets accumulated in the kidneys. Its mode of excretion actually is renal. Its mode of excretion is renal. So hence, in a patient who has got very low GFR, like less than 20 to 25, we will not be using it. So that way, if you have to take the statement as right. This is a kind of question where your overall idea, nobody knows how much renal excretion, 65%, 70% like that. But what has to come to your system is that, okay, this is one drug like SGLT2, Findranon, all these things are actually speaking given a GFR bar. It's not like metronidazole, which can be given at any GFR. This is not that way. We know below 25 ml per minute can't be given. We have stressed on that. That means it is likely to accumulate. So that way 1, 2, and 3. Okay, not easy question, but that's where I'm saying the soul of the topic, the understanding that you have, that will help you. Cardiology question, this is, I think they themselves should get fed up of asking this. No, so many times hypertrophic cardiomyopathy, everything about hypertrophic cardiomyopathy, asymmetrical septal hypertrophy, ASH and SAM. So I've always kept talking about ASH and SAM. ASH is asymmetrical septal hypertrophy, and SAM is your systolic motion of the anterior mitral leaflet. Okay, and we always say, who is the hero? SAM is the hero. So that's it. So this is a very simple question. Then same pathophysiology of heart failure, again too easy. Fever, anemia, and thyrotoxicosis are all basically high output heart failure. So this is basically not equal to high output. So again, all the students got it right. Which of the following will have large A waves? A wave is basically equal to a right atrial pressure. P wave is equal to a right atrial enlargement. So A wave, P wave are two different questions, but for both the questions, it is about the atrium. Atrium getting enlarged, atrium actually increasing its pressure because there is resistance. So always the answer has to be tricuspid stenosis. There is no doubt about it. P pulmonale is about right atrial enlargement. A wave is about right atrial pressure. What are you measuring? You're measuring only right atrial pressure. So easy cakewalk questions in cardiology. This is exertional dyspnea and pedal edema. Echo shows dilated LV with reduced systolic function. So what are you actually dealing with here? We're dealing with HFrEF. So we are dealing with HFrEF. HFrEF, what is false is the question. So beta blockers are indicated in chronic management. We know what is called as the fantastic four in heart failure. So naturally, ejection fraction will be reduced. That's why it is called as HFrEF. I don't know whether that was an option or not. Every time you are having left heart failure, that puts you at risk of developing right heart failure and literally having been associated with pulmonary hypertension also in a lot of patients, because we are talking about class 2 pulmonary hypertension. What is the meaning of class 2 pulmonary hypertension? That is due to an increase in left atrial pressure. And what is left atrial pressure? Equal to left ventricular end diastolic pressure. LVEDP is equal to LAP is equal to pulmonary capillary wedge pressure. That is a dictum statement. Why do you have an increase in LVEDP? Because a chamber that cannot contract adequately cannot relax adequately as well. So LVEDP will increase. When LVEDP increases, LAP increases. When LAP increases, you will have pulmonary capillary venous pressure increasing. You'll be having pulmonary hypertension. So all these are right statements. And you know what are the biggest dangers in a patient with somebody who's having systolic failure? I've told you, the risk of sudden cardiac death due to emboli, the risk of arrhythmias, all these things we have discussed. So that's why. So LVDP is equal to increased LAP and equal to increased PCWP. So that's the reason these patients will get dyspnea also. Initially with more than ordinary activity, then they progress to NYHA 2, 3, etc. Long-term anticoagulation is not needed for this patient. When you think of a patient who's having HFrEF, what are the dangers? The dangers in a person who's having HFrEF, we've discussed that. Now, only by the time you come to NYHA 4, there is mortality because of pump failure. NYHA 2 and 3, there is so much mortality due to emboli. NYHA 2 and 3, there is so much of mortality due to sudden cardiac death, arrhythmias. So because of which anticoagulation is required. So that's why this is the wrong answer and the other three are correct. Okay, clear. Yes. We go to few rheumatology questions. 40-year-old female patient presenting with dry mouth, gritty sensation, normal anion gap, metabolic acidosis, hypokalemia. I don't think I have to tell you anything with respect to this. If you get this right, then you better divorce from me and go away, because we basically have nothing to do with each other. I don't think I like a topic more in medicine than Sjogren. And Sjogren is associated with type 1 RTA, that is what is called as your normal anion gap, metabolic acidosis, and associated with hypokalemia. So all that is very clear. What is the best investigation in Sjogren? Gold standard investigation in Sjogren is always what? Gold standard investigation in Sjogren is your minor salivary gland biopsy. So it's your labial biopsy or minor salivary gland biopsy. That has got 3 points, and that is the best investigation. Now here, if that is not there, then you can probably go for anti-ROLA. So if minor cerebral gland biopsy or labial biopsy is not there in the option, then we have anti-RO, anti-LA, because that is what also gets 3 points. If you look through this classification which I have taught you, labial gland biopsy is the gold standard. Also antibodies, both have got 3 points. Then your Schirmer test, ocular staining, as well as your salivary gland, salivary flow, all have got 1 point. So out of this, best answer is always Schirmer and antibody measurement, but antibody is there in that option, means that is the answer. Gold standard is always your minor salivary gland biopsy. Salivary scintigraphy and unstimulated flow rate and all, nobody knows, so nobody even thought of it. Improvement on trial with methyl, nobody wrote. And serum ACE levels and X-ray, they're thinking of sarcot, which is not a picture at all. So that's the reason I think majority got it right. Okay. Then they had asked a question on Boutonniere deformity, which is your flexion of your PIP and hyperextension of your DIP, which again 100% students got it right. This is kind of a tough question. That's what I said. 20 questions are tough. This is the first tough question we are dealing with. A middle-aged female having RA. So they're talking about RA here. and she's enrolled on a trial of epigenome modifying drugs. That means epigenetics. When we talk about the disease risk factors, we talk about genetic factors, environmental risk factors. In RA, the major environmental risk factors: smoking, also porphyromonas gingivalis. We've discussed that. Then genetic factors are there. In genetic factors, we have HLA related factors and non-HLA related factors. Under the HLA related factors, we talk about the HLA DRB104, the QICRA motif, amino acid 70 to 74. That is what we always talk about. Then we have the non-HLA things. Under the non-HLA things, we have epigenetic modifications like methylation, acetylation, etc., etc. They are the epigenetics. Okay, so epigenetic modifying drug is what they are talking about, but we haven't actually got a drug like that which can directly modify epigenetics so far. After 8 weeks, our symptom improve. All the following are true regarding this condition. So all these epigenetics modifying drugs, all these epigenetic modifying drugs have to somehow act by blocking the T cells or the B cells, because it is a disease which has got to do with both the T and B. So any epigenetic modifying drug has to do what? Block the T cell or the B cell, because the disease is all about what? Dendritic cell T cell interaction, DCT interaction, T cell activation, B cell secondarily getting activated, T cells going and activating macrophage, macrophage producing TNF alpha, TNF alpha going and acting on the bone, etc. That is the pathogenesis of the disease, as we have discussed so many times. So this is something that has to be affected. So when this has to be affected, the drug has to block TNF alpha or T or B or something. It cannot directly bind to the cytokine receptor to produce inflammatory, block inflammatory signaling. Then that drug has got basically nothing to do with what? Epigenetics. It is basically going and directly acting on the cytokine receptor. And there are only few things like insulin or EPO or something which directly goes and acts on the cytokine receptor to block signaling. So obviously it can't be that way. So that is my logic for answering this. But I would put it as a very tough question, in fact, because for somebody who reads this first time, he may not be. But somebody who thinks sensibly that TB, etc., are into pathogenesis, any drug which we have to find out can actually that way. These three options are going in the same direction, can actually figure it out. That is the beauty of elimination. Okay, we go to neurology question. Again, purposeless dance-like movements involving the upper limb and lower limb. Aggressive and irritable over the few months. MRI shows hyperintensities of the caudate nucleus. So basically there is motor issue, there is mood issue, there is movement issue. So when there is motor, mood and movement issue, obviously you know that this is a caudate lobe getting atrophic as well. So all about a subcortical issue, and a subcortical issue here is Huntington's chorea. Again, not much of an issue for most of the students. They've been able to write down corticostriate fibers are involved in this. That's the reason we have prefrontal cortex getting involved and a lot of executive dysfunction. We have chorea, dystonia, and sometimes Parkinsonism symptoms in these patients, primarily because again the subcortex is getting involved, and then few psychiatric symptoms. It's better to actually remember it as mental, motor, and movement. These are the three things that get affected here. And movement is all about either Parkinsonism or something like a coriform or dystonic movements. Mental is all about cognition because of the corticostriate fibers, and mood is all about psychiatric, depressed mood, apathy, again because of the frontal lobe involvement. Okay, in case of myasthenia gravis, repetitive nerve stimulation test shows decremental response. Another tough question. What is the rationale explaining this? So in myasthenia gravis versus Lambert-Eaton myasthenic syndrome, what did I tell you? Baseline Cmaps, if you take, baseline Cmaps are actually speaking normal here. Baseline Cmaps are very, very reduced here. Then we have low frequency repetitive nerve stimulation test, and we have high frequency repetitive nerve stimulation test. In low frequency repetitive nerve stimulation test, there is a decremental response in myasthenia gravis and a variable response in Lambert-Eaton myasthenic syndrome. In a high frequency repetitive nerve stimulation test, there is increase with myasthenia gravis, and there is heavy increase, more than 100% increase with Lambert-Eaton myasthenic syndrome. This is all what I have taught you. So with that, you know, decremental response, when they use the word decremental response, it shows that they are looking for myasthenia gravis. So you can say that there is reduced acetylcholine receptors on the postsynaptic membrane, and most of the people have actually answered this. But the problem with this question is, if this is the common thought process, and I think if you do this also, you are justified, because 99% of the students are going to do this only. My question is, have they asked the rationale behind RNST, or have they asked the rationale behind the disease? What is the rationale behind the disease? Means decreased number of acetylcholine receptors on the postsynaptic membrane, antibody is going and attacking the acetylcholine receptors, acetylcholine receptor antibody is there, that is the more specific antibody, and so on and so forth. But if they are asking you, what is the rationale explaining the repetitive nerve stimulation test? If they're asking you what is the rationale explaining the repetitive nerve stimulation test, then the amount of acetylcholine released per impulse normally declines on repetitive activity. This is the one that actually accounts for the decremental response to repetitive nerve stimulation test on electrodiagnostic study. This is from all books, and this is something which generally people who have an idea about the RNST know. At your level, to know about RNST is not possible. And I have taught you what's the difference between myasthenia and Lambert-Eaton myasthenic syndrome, because that is what they ask normally. And even in that, just like blindly studying this is decremental and that is incremental, we have gone for the baseline CMAPs, the low frequency, the high frequency. But the exact reason behind why it happens that way is the amount of acetylcholine released per impulse normally declines. So if you have to mark the correct answer, this will be the correct answer. But I don't know whether they ask this. What is the rationale behind the disease? If they ask you, then of course it is decreased receptor. But the rationale behind the test, if they are asking you, that is decremental response on a low frequency RNST, if they are asking you, then the answer is acetylcholine release less or depletion of acetylcholine. So I am sorry for that kind of a question. It's very tough, like the other question of the epigenomics that we were discussing. This is a tough question. But remember, first ranker has scored only 162, right? Because you have the liberty to get how many questions wrong? 38 questions you have the liberty to get wrong. So even if you get 50 questions wrong, you are still inside the first 100. So which means in a tough exam, that goes without saying. And people who mark this are perfectly justified in doing the same. It's just that the examiner has got one step ahead of you. Sometimes the ball bounces more than you expect. Okay, that's it. Then what area is responsible for scanning the visual field? Again, all of you should get this right. You know, frontal eye field is in the frontal lobe. Yeah, frontal eye field is in the frontal lobe. We've discussed a lot about that. So with the frontal eye field, you can look to the opposite side. Yeah, with your frontal eye field, you are connected to the opposite side PPRF, and the opposite side PPRF is connected to the sixth nerve nucleus, and through the sixth nerve nucleus, your lateral rectus gets activated, and you look to the opposite side. It's a very simple question. So scanning is basically through your frontal eye field, and frontal eye field alongside with your Broca's area, alongside with your prefrontal cortex, the supplementary motor cortex, and all these things form the integral part of your frontal lobe. And we've had a discussion on the frontal lobe per se. And the extension of this we have again done is internuclear ophthalmoplegia, 1.5 syndrome, and all those things. Worsening back pain and weakness in the limbs, what wouldn't support a diagnosis of compressive myelopathy? In common sense question, whenever you get a question on compressive myelopathy, draw the spinal cord, draw the gray matter, draw the white matter, and you know that this is the inside. So this is the gray matter. In the gray matter, you are having the ventral horn. This is basically what we call as the anterior horn cell. Then you draw the white matter. White matter, we are having the corticospinal tract here. Corticospinal tract, which is equal to cervical, thoracic, lumbar, sacral, medial to lateral. Then we are having the spinothalamic tract, again CTLS, again you know that. Then we have the posterior column fibers here, where it is equal to SLTC. It is equal to SLTC. So medial to lateral is sacral to cervical, medial to lateral. Other things are cervical to sacral, medial to lateral. So this much you know. If you know to draw this much, we know that the roots are being actually formed. And see, we have the root coming out here. There is a ventral and dorsal sensory, and the dorsal root ganglion is actually situated outside. DRG is situated outside. This much you know. So when you say compressive myelopathies are divided into intramedullary lesions and extramedullary lesions. Extramedullary lesions are divided into extramedullary intradural lesions and extramedullary extradural lesions. This much you know. So we will talk about extramedullary because extramedullary is more common, and compressive myelopathy is a term which we generally reserve for extramedullary. Although calling intramedullary as compressive also no problem. So the tumor is coming from outside and compressing like this. When the tumor is coming from outside and compressing like this. So naturally, when it is coming from outside and compressing like this, at the level of lesion, because you're hitting the root as well as you're hitting the anterior horn cell, you'll be having complete element at the level of lesion. So at the level of lesion, complete element, and below the level of lesion, what will you get? Complete human, because the human fibers are cut off and that inhibitory effect is completely gone. So at the level of lesion, you can have elements. So hypertonia is correct. And then neclonus is of course correct, because below the level of lesion, you'll be having human findings. Okay, so all this is done. Then the question that you have is negative Babinski sign is definitely wrong, because you are having positive Babinski sign. You are having extensor plantar response. Every time you are having a proper compressive myelopathy compressing on your human fibers, you will have all the superficial reflexes lost, and your DTR below the level of lesion are going to get exaggerated. And among the superficial reflexes, the exception is your plantar response. The plantar response being a withdrawal reflex, that will actually be equal to extensor plantar. So I am not sure whether the options are these were the options presented to me. In that case, both these options are actually wrong, because cremasteric reflex being a superficial reflex, you will lose cremasteric reflex, no doubt about it. Babinski sign will become positive. So which of the following does not support a diagnosis of compressive myelopathy? Means A and B are not supporting the diagnosis of compressive myelopathy, whereas hypertonia at the level of lesion is okay. Knee clonus is also okay. Below the level of lesion, you get hyperreflexia, so that is also okay. But remember, superficial reflexes are lost in compressive myelopathy, and your deep reflexes are exaggerated. Exception is your plantar, which is extensor. Anybody who has gone near the ward with seen one or two patients, knowing this. So please see whether it's the right option. Out of the statements, out of the options given to me, this is what I presume. There are people who say that it was given as Babinski sign positive. So if Babinski sign is positive, then the correct answer is normal cremasteric reflex, as cremasteric reflex will be lost. Okay, most common site of a berry aneurysm is your anterior cerebral artery. Always know the final branches of your internal carotid. The most important final branches are, what are your final branches? This is your anterior cerebral artery. This is your middle cerebral artery. Yes, anterior cerebral artery. This is your middle cerebral artery. And what I'm drawing down is basically my posterior communicating artery. The two vertebral arteries join together to form the basilar artery, and the basilar artery ends as to posterior cerebral artery. So posterior cerebral artery you can actually see here, and you can see this connection, which is called as your ACOM, arising from the anterior cerebral artery. So anterior cerebral artery we can actually see here. So ophthalmic artery, posterior communicating artery, your anterior choroidal artery, as well as anterior cerebral artery and middle cerebral artery are coming from the terminal branches. There are 5 terminal branches, out of which from the anterior cerebral artery or anterior cerebral artery ACOM junction is where you are having maximum berry aneurysms. Okay, that's what. So basics, if right, you will be able to come to the answer. That's it. Not given in status epilepticus. It could have been a tough question, but because ethosuximide is there and it is not given for anything, I told you, in the world, because even for absence, everywhere we are giving valproate. We are giving valproate, just because of the reason that valproate has got multiple actions, even if it is a typical absence, atypical absence, myoclonic, or atypical myoclonic, or juvenile myoclonic, or whatever it works. So that's why ethosuximide has no roles. If you know that, that's more than fine. Then otherwise, treatment of status on one line, what to give, we've talked about the role of lorazepam or midazolam or diazepam and all these things. And through the other line, we have talked about the role of phenytoin or fosphenytoin or your levetiracetam or valproate. All those things we have actually discussed. So again, this is an easy question because the options were not confusing. Okay. Respiratory system, little confusing this time. This is a question on pulmonary artery hypertension. What are the prostacyclin receptor agonists? I have mentioned very clearly iloprost, epoprostinol, and the oral drug that has come, that is called as Celexipac. And we have discussed this very, very clearly. People who are having NYHA 1 to 3 symptoms, we need only ampersand and tadalafil combination. But NYHA 4 symptoms in primary pulmonary hypertension or class 1 pulmonary hypertension, you require prostaglandin analogs, and after which iloprost, epoprostinol are the ones routinely used, and the oral drug that is available is called Celexipac. So this is a little tougher question. I put it as a very tough question because unless and until you have discussed, you've gone and studied management of pulmonary hypertension, which is something we don't do in a routine revision video, or when we try to concise, we generally don't teach that much. But pharmacology also, this might have been taught in a different way. But if we watch the original content and you know the soul behind management, and that they have asked NYHA 2-3 what to do previously, there the answer was ampersand and tadalafil. Ampersand is what endothelial antagonist. What is tadalafil? Phosphodiesterase 5 inhibitor. So there we have actually talked about this. So if you have got that, this is a PYT, and that I need to know a bit more about that, you may get the answer. But still, I would put it as a tough question. Then this gold criteria question, I think this has come so many number of times. I am not sure why people go wrong with respect to this. Maybe because their understanding is a little poor. Let us get the understanding very clear that FEV1 by FVC will be definitely low, less than 0.7 in somebody who is actually having a COPD or somebody having an obstructive airway disease, because FVC is your forced vital capacity, which does not take time into account. So even if you are having a abnormal lung, if you are giving me more and more time, I will still be able to exhale out. So it just takes volume into consideration. So FVC can't be banged on. But because first 1 minute amount of air going out is obviously dependent on my effort, that will come down. So when you plot it as a ratio, FEV1 by FVC ratio is definitely going to be low in obstructive airway disease. No doubt about it. Correct. Now, in this FEV1 by FEC low in obstructive airway disease, if it is reversible, that is called as asthma. And when it is not reversible, you call it as COPD. So reversibility 12%, 200 ml, all that we have seen. Once it is not reversible, with what? With a short-acting bronchodilator, then you are actually looking into the percentage of FEV1 predicted. So percentage of FEV1 predicted more than 80%, 50 to 80%, 30 to 50%, less than 30%. And less than 30% is what we call as very severe. Okay, so this is what it is. FEV1 by FEC less than 0.7. That is after a bronchodilator, inhalation that you're talking about this, where it is not reversed. And then the percentage of FEV1. The percentage of FEV1 is less than 30%. Okay, what is the critical value to develop resting hypoxemia? I believe they want very severe. That is what I presume. So in that case, the answer is 30%. This is my presumption. I think that should be right also. Man with third question on COPD comes with acute exacerbation, which I think most of you would have managed in your wards and most of you would have seen during your house urgency. Somebody comes with a COPD exacerbation. What are you going to do? COPD exacerbation, let us take it very simple. Any exacerbation with respect to COPD, you need to give the patient inhaled bronchodilator. So that is there. Then this patient is definitely having moderate to severe. You have to go for steroid. Very, very important. Steroid oral. And antibiotics is optional, but most of us give antibiotics because the single most important reason for worsening is what? Is the respiratory worsening due to a respiratory infection per se. So that is again something where we give the patient antibiotics. And then more than this, what you require means you have to basically hospitalize the patient and start on NIV if there is hypoxia or hypercarbia. So here there is hypercarbia. So I would actually admit the patient, start on NIV, put the patient in the ICU. Antibiotics is correct. Steroid is correct. Nebulized bronchodilator is correct. Antiviral routinely we don't use. So I don't think antiviral will be there, because even if you go with the guideline, that is not there, and generally none of us actually resort to giving antiviral for a patient who comes with the COPD and an exacerbation. So this is what we presume. So it's a very practical question, nothing to study about. Then people living with HIV, 3 months X-ray. This is like a second year MBBS question, nothing to discuss on that. Metastasis would have bilateral involvement, lung abscess would have air fluid level, aspergillosis, obviously not like this. 48-year-old woman presents with progressive shortness of breath and a dry cough. So they're looking at ILD. HRCT is given below. All the following are true about this condition. So probably they're looking for ILD, and you can see septations, you can see honeycombing. So all these things is what I presume they've asked. So they've asked UIP pattern. I think so honeycombing is most characteristic of UIP pattern. Vaccination is mandatory for these patients. Only CTD associated with UIP pattern is rheumatoid arthritis. And in UIP or in ILD, what do you hear? You hear fine crackles, not coarse crackles. Where do you hear coarse crackles? Bronchiectasis, and this is not bronchiectasis because that is full of cough and full of spute. Okay, again, application type question, but if you know the core, you will not fall behind. The point is you know the core about ILD. What's the core about ILD? Majority patients have IPF. IPF histologically is called UIP. UIP is characterized by destruction of lung architecture, septations, honeycombing, traction bronchiectasis, and cystic changes. So look into the CT whether these things are actually there. I presume such a CT was given. This is not the original CT. If that is not there, you see a completely normal lung, and on that completely normal lung, you'll be seeing just a glass-like thing. That is called GGO. The moment you see GGO, you think of NSIP, otherwise you think of UIP. All the CTDs you think of GGO, NSIP, everywhere it is GGO, NSIP. And the only place where we get UIP is RA. That's why RA has got a poor prognosis with respect to ILD. Then comes inhaled beta-2 agonist. I've told you this so many times. When somebody comes for inhalation of beta-2 agonist, what is that you should be looking for? Heart rate you should look for, tremor you should look for, potassium you should look for, because it is not hyperkalemia, it is hypokalemia. Then COPD with type 2 respiratory failure is chronic bronchitis, which we've discussed about the fact that parenchyma is getting involved. So low FEV1 by FEC, increased RAID index, correct bronchial wall inflammation. All the time we've discussed, that's why you have so much of cough. And lung compliance is equal to what? Your elastic recoil pressure, right? Here elastic recoil pressure is so low, your attachments are all lost. Because it's so low, it's very easy to inflate the lung. The moment it's very easy to inflate the lung, your compliance is more. And because your compliance is more and so easy to inflate the lung, the graph actually shifts down and to the right. Whereas in ILD, it's very tough to actually inflate the lung. So the graph shifts up and to the left. Which graph? P by P graph. Okay, please go and study that. Yes, so from respiratory, we go to liver. Question number 1, liver again, tried and tested kind of a question, which I think almost everybody discusses, and we've had so many questions on this type as well before. So let's again quickly recap. I think you'll be knowing this. HbA1c titers are unknown. Then you have to basically take the patient, anti-HbS titers, sorry, are unknown. Then probably you have to take the patient as a fresh patient. So here anti-HbS titers are not given, so you have to take it as a fresh patient. Otherwise, also they've given it that the vaccination is a non-responder. He's a non-responder 3 months back. So basically, you have to take it as a fresh case. When you take as a fresh case, somebody who has had a needle stick injury, you have to be giving immunoglobulin, plus you need to be giving the vaccine. 0.06 ml per kg is your immunoglobulin, has to be given as early as possible. Textbook says within 7 days you can actually give, but the best response is within 72 hours. So HBIG single dose with HBV vaccination, first dose beginning now, then 2 more doses, 012 or 016. 2 doses of HBIG, nowhere it's there. Checking titers and deciding and all, nothing like that is ever discussed. So only thing is, sexual route you can actually wait till 14 days. You can give up to 14 days, not wait till 14 days, give up to 14 days. Others can give up to 7 days, but everywhere the best response is within 72 hours. Okay. Second question on liver is about these antibodies and a lot of them. So I think this is again something which all of you know. Anti-HAV IgM non-reactive. Okay. Anti-HAV IgG reactive means you have had hepatitis A virus exposure in the past. So hepatitis A virus exposure in the past, and any hepatitis A virus exposure in the past is equal to saying that you have recovered, because at the end of hepatitis A virus infection, if you have crossed over to IgG, then automatically means that you have recovered. HBsAg is non-reactive, but anti-HBC total IgG is reactive and anti-HBC IgM is non-reactive, which means anti-HBC IgG is reactive means you are having a chronic hepatitis B. Can you say you're having a chronic hepatitis B? No, because HBsAg is actually negative. So then the only thing that most of the time you can say is that you have a remote HBV infection. Remote HBV infection. Now the titers of hepatitis B, HBsAg have come down. That is not detectable anymore. Only anti-HBC IgG is detectable. Anti-HCV IgG reactive, which means anti-HCV IgG reactive, but nothing is actually given about HCV RNA. So you can't say anything about hepatitis C virus. It may be a present or a past or a recovered, present or past or recovered. So whatever it can be. Anti-HCV IgM non-reactive, anti-HCV IgG non-reactive. So that's all done. So can it be a past HIV infection or received vaccine for HIV? That's a correct statement. HCV DNA titer should be estimated correct by RT-PCR, correct statement. HBV infection in the remote past, again correct statement. Chronic hepatitis B infection, no, you can't say. Chronic hepatitis B infection can be said with S gene or A gene mutation, but that's a rarity. When you have a chronic hepatitis B infection, you are HBsAg positive beyond 6 months and you are having anti-HBC IgG. So because of that, that has to be taken as wrong. Very conceptual question, purely based on whether you know your dynamics with respect to liver function test, with respect to hepatitis B, A, E, etc. everything. And this I have discussed in toto, so there is no way you can miss this. Then chronic liver disease presenting with jaundice and melena. Again, very sensible, thought out question. On examination, there is ascites and mild hepatosplenomegaly. So you are having a decompensated chronic liver disease with portal hypertension with splenomegaly. So you're taking a patient with chronic liver disease with portal hypertension with splenomegaly decompensated. Why do you say that he is decompensated? Because he has got ascites. The moment he is having ascites, the dangers that he runs are, one, from ascites, he can go to SBP, he can go to HRS, he can go to HPS. That is one way that he can actually go. Ascites, again with SBP, you can go to HE. So that is also there. So this is the patient status, but it is given that the patient is having melena now. So melena is equal to active UGI bleeding. So the patient is having active UGI bleeding. Which of the following is not a part of management of his encephalopathy is the question. So ascitic tap to rule out SBP, you will do, because ascites patient can pop off due to SBP. Check for HRS in everybody who's having ascites. We will do renal function test and we will see if structurally the kidney is normal and there's only a functional impairment that is due to splanchnic vasodilatation and intrarenal vasoconstriction. You say that is HRS. Then the question is, do you have to give the patient IV octreotide or you have to give beta blocker to stop variceal bleed? To stop variceal bleed, nobody can give beta blocker. Beta blocker in a patient who is not having any active bleed, who is diagnosed as a CLD, who is diagnosed with portal hypertension, then you do the upper GI endoscopy. Upper GI endoscopy, you are seeing moderate to large varices. On these moderate to large varices, you are starting the patient on beta blocker. After starting on beta blocker, if it is not responding, target HPPG is not achieved, or you are having intolerance to beta blocker, then we go for endoscopic variceal ligation. Actively, when the patient is bleeding, you need some kind of a vasoconstrictor to arrest your bleeding, and that is where terlipressin comes into play or octreotide comes into play. So read the question properly. If they have not mentioned this theory of melena and just having jaundice and the other history, and there is no active GI bleed, then we need to do endoscopy. We need to look for varices. If there is mild to moderate varices, only follow up. There is moderate to severe varices, you will start the patient on beta blocker and then you look for the response. Okay, so this is the route. Okay, that question on decompensation, if you have understood properly the theory of decompensation that I have told you, what is the meaning of chronic liver disease? What is the meaning of portal hypertension? A patient with chronic liver disease can have portal hypertension because of the reason that P is equal to F into R. So R increases or F increases, you will have portal hypertension. R is resistance. Why does resistance increase? Because nodules compressing on the sinusoid. That causes increased resistance, or sinusoidal vasoconstriction, sinusoidal defenestration. These are the reasons. So now R increases. Okay, R increases and now P increases. When P increases, what happens? P increases means portal pressure increases, splenic pressure increases, splenomegaly, hypersplenism, tapping of platelets, thrombocytopenia, all these things. Now what happens? Because of loss in peripheral vascular resistance, complete loss in peripheral vascular resistance due to splanchnic vasodilatation as well as due to change of the flora, what do you have? Hyperdynamic circulation. Hyperdynamic circulation means what increases? F increases. Again, P is equal to F into R. Okay, same theory. We're not going for anything complex here. So esophageal variceal bleeding or any kind of variceal bleeding you're thinking with active bleeding, which maybe UGI bleeding, which is any kind of hematemesis or melena, endoscopic therapy for control of bleeding, yes, you can give vasoactives, you can give antibiotics, or if not working means, then you have to naturally go for tips. Okay, we have discussed this again. Surgeon has also discussed this. Most common cause of diarrhea in adults, rotavirus in children, norovirus in adults. Onion skin fibrosis is all about primary sclerosing cholangitis, which is now considered to be a IgG4 related disease. Again, very important topic consideration. Differences between PBC, PSC, highlighted so many number of times. The PYT again can come for the exam. Karyotype of Fortis is XY deletion 15. This is a question which I'm not sure, because Prader-Willi and Angelman both can have this. Some of the people are saying that there is obesity, hypogonadism, and mental retardation. So in that case, please mark it as Prader-Willi. We have discussed it under congenital hypopit. Angelman is more of a happy puppet. So we've discussed the differences. Very easy question. Mantle cell lymphoma. 11-14 translocation. What happens when the cell goes into the mantle zone? When it goes into the mantle zone, don't call it as mantle zone, because then you may be prompted to write the answer as mantle zone lymphoma. No, this is marginal zone lymphoma. So always have the habit of writing it as MCL itself. This is mantle cell lymphoma. So the cells which are in the blood are called as the nave cells. And from the nave cells, normally they undergo apoptosis. If they don't undergo apoptosis, then they become converted into monoclonal CLL cells that we have discussed. So from the nave cell population, few are being sucked into the lymph node and they go into the mantle cell layer of the lymph node. And in the mantle cell layer of the lymph node, we have this cyclin D1, as well as we have this CD5 and SOX11. So these are the characteristic markers. We discussed this so many number of times. 5 positive, 10 negative with 23 positivity is equal to CLL. 5 positive, 10 negativity with 23 negativity is equal to mantle cell lymphoma. And 10 positive, 5 negative and 23 positive is what we call for the germinal central malignancy. So 5 plus 10 minus 23 plus is equal to CLL. 5 plus 10 minus 23 minus is equal to mantle cell lymphoma. And 10 plus 5 minus and 23 plus is equal to your germinal central malignancy. So that's why SOX, cyclin D, CD10. CD10 is wrong here. SOX11 and cyclin D are the correct answers. Okay, right. This is also a PYT because they've asked exactly a few years ago with regards to SOX11. That means that mantle cell lymphoma is a hot topic. If not mantle cell lymphoma, they will ask you DLBCL or Burkitt. So that NHL, which are the B cell NHLs, are extremely important. So you know that it is an exam zone. So once you know that it is an exam zone, there is no way that we can actually get past this. This is another question on microcytic hypochromic anemias, which is always an exam zone, a very much PYT kind of a topic, where they've actually gone for Menzer index this time, which is MCV by RBC count. So MCV by RBC count is your Menzer index. Less than 13 and more than 13 is the cutoff. More than 13 is iron deficiency anemia. Less than 13 is your beta thalassemia trait, or what we call as the thalassemia minor. How do you understand this? Very simple. In a beta thalassemia trait or a thalassemia minor, there is nothing called ineffective erythropoiesis. Erythropoiesis does happen. Okay, so there is no point of increased iron absorption or anything. So erythropoiesis is happening. Only thing that your HB will be somewhere around 10 or something like that. So there is no reason for your RBC count to drop down here. It's only your MCV that drops down. So that's the reason why the ratio comes low. Whereas in iron deficiency anemia, MCV is low, RBC count both are low. So the ratio is more or less maintained. So this is a clear case of beta thalassemia trait or thalassemia minor, where you're having beta, beta 0 or beta, beta plus. And that's why the answer is hemoglobin electrophoresis. Okay, it's a very clear answer. So you don't have to have too much of confusion with respect to this. Please go back and see sideroblastic anemia, thalassemia trait or thalassemia minor, iron deficiency anemia, anemia of chronic disease, how we differentiate, everything is very clear. Target cells can be seen in so many conditions. So again, very, very non-specific. Liver disease, you can see target cells. The HBC disease, you can see target cells. Tal trait, you can see target cells. Even iron deficiency anemia, you can see target cells. So that is non-specific. Increase in RBC count is something that you can't associate with iron deficiency anemia. Menzer index is MCV by RBC count. If you know that also, you'll get the answer. Okay. Then Hemoglobin 9.2, again microcytosis. So iron deficiency, thalassemia, lead poisoning is among the causes for sideroblastic anemia. I don't know whether they put such an easy question, 1, 2, 3. B12 deficiency is the only thing that is not right. Again, go and study the causes for sideroblastic anemia, inherited causes for sideroblastic anemia, acquired causes for sideroblastic anemia. Inside inherited causes, ALA synthase defect in pediatrics, acquired causes SF3B1 and your myelodysplastic syndrome, very important. Lead poisoning, very important. So all those things have been asked again and again. Then NS1 positivity, fever for 5 days, no bleeding manifestations, HB9, platelet count is 20,000. Which of the following should be used in the management of the patient? So paracetamol, of course. Platelet transfusion, PRBC transfusion, steroids, no. But if I were treating this patient in the hospital, 20,000, below 20,000 with bleeding manifestations you give, and below 10,000 without bleeding manifestations you give. 20,000 now can become 16,000 in a few minutes time, so a few hours time. So you would be on the safe side and give some platelet. But for an exam question, it is only one. Then few Dolby nephrology questions. Dolby nephrology questions, I mean, nothing to actually study here. Periorbital edema, pedal edema, urinary protein 5.2, cholesterol 310. So what are you dealing with? Nephrotic syndrome in a child. Nephrotic syndrome in a child, what are you basically looking at? Proteinuria is there, correct? Hyperlipidemia is there, hypoalbuminemia is there. But increase in creatinine is not among the criteria. And we say most of the patients who are actually having nephrotic syndrome have a normal RFT. I have mentioned this so many number of times, more so children. The moment you are having abnormal RFT in a case of nephrotic syndrome in a child, it's very rare to see. Adult also, it's not quite common to see. Then you know that it is not MCD. That's what you can say. It's not MCD. Adult and all, if you are seeing a nephrotic syndrome where RFT is slightly altered, then you are thinking more in terms of FSGS. You can think in terms of membranous, etc. But generally, as a rule, nephrotic syndrome is equal to nephrotic range proteinuria with hypoalbuminemia or edema. Nephrotic range proteinuria with hypoalbuminemia or edema. Supporting evidence is hypercholesterolemia. Okay. Then 5-year-old child, 4 plus proteinuria, unresponsive to steroid therapy, no history of hematuria, hypertension, segmental sclerosis, and hyalinosis, which is what we call as focal segmental glomerulosclerosis, which involves the corticomedullary junction. What is the most likely diagnosis? FSDS. Again, children, it is MCT 90 to 95% of the time. 4 weeks, if you are giving steroid and there is no response, you call it SRNS. SRNS is the indication for biopsy. If you do biopsy in SRNS and you stand for all the genetic panel studies also, because you may get a genetic form of FSDS, which can be autosomal recessive due to podocyte mutation or dominant due to alpha-actinin TRPC6. So many things are there. Anyone can actually become positive. Then you understand that you cannot, or not cannot, you shouldn't unnecessarily immunosuppress a child because it is resistant to all forms of immunosuppression. So then we can plan a transplant. Again, core idea is very simple. If you have the core idea, you will keep landing at the right answer. As long as you're mugging up and as long as you're going for recall and trying to recall that from the book, you will still end up at a very mediocre range. If you want to break that mediocre range and go to that 150 plus range, 150 plus range is when you break into the first 100. At least you get into that 140 plus range. In this kind of an exam, your understanding has to be good. Your understanding, whatever method you adopt is up to you. Whatever resource you use is up to you. Whether you will learn in detail or not is also up to you. But the fact is that your understanding has to be good. When the question comes over the exam, thoughts have to flow into your system. And that has to actually translate into the answer. During inspiration, systolic BP decreases because right side filling is there, push is there to the left side, and you are having decreased output from the left side. So it's basically increased venous return to the right side, transiently reducing the LV filling. We've discussed this in detail now because the fall in intrathoracic pressures are being transmitted to the cardiac chambers, and SVC is actually speaking an extra pericardial structure, but it is actually speaking extra thoracic. So that's the reason why that fall in pericardial pressures being transmitted to the cardiac chamber is not so much applicable for SVC. So SVC-RA, some kind of a gradient is being created. So more blood will come to the right side, more blood will come to the RV, that will push on to the LV, and there is a transient decrease in output from the LV, and that is basically what we call normal. When there is a fall in systolic BP by more than 10 millimeters of mercury during inspiration, you call it as paradoxis. So there is nothing paradoxical about it. So better answer is it is pulses normalis aggregans. Most common regulatory mechanism of magnesium. Magnesium, potassium, I told you, kept on telling you, again telling you, are handled only by the kidney. The moment you are having magnesium, potassium, or phosphorus disorder, nothing to think, just to keep thinking about kidney. The moment you are having hypermagnesemia, that because kidney is not excreting magnesium. The moment you are having hypomagnesemia, that is because kidney is excreting out lot of magnesium. Same way about potassium also you can say. The moment you are having significant hypokalemia, that is renal loss. The moment you are having significant hyperkalemia, that is because the kidney is not excreting potassium. Okay, in the case of phosphorus, hyperphosphatemia is due to, again, renal failure. but cell shift is there. That's not that significant. Hypophosphatemia is due to renal loss. Okay. Invasive pulmonary aspergillosis is all about febrile neutropenia. We have discussed this so many number of times about neutropenic infections. We talked about a case of hairy cell leukemia also. Wherever you are having neutropenia, especially long-standing neutropenia, like in hairy cell leukemia, aplastic anemia, the patient is always prone for invasive aspergillosis. Iris question was there when to start ATT, ART, and all those 2 weeks. It has been asked 1,000 times now. Risk factors for DVT, as usual, routine questions with respect to OCP, smoking, and all that. Very easy. HIV pre-exposure prophylaxis, pre-exposure prophylaxis, the tenofovir emtricitabine regimen. We have talked about the management of HIV, the pre and post. Please go back and see again. Every time you get a question, Sesta maybe again they're fed up of asking so many times. Cryptococcal meningitis with amphotericin B, cytosine, again being asked 100 times, 200 times. So those are all simple PYQ, you can say. It's not even a PYT. So we basically have 120 questions like that. That's what I'm trying to tell you. 120 questions of sort which you can just by recall keep answering. You can just go back to that page in your notebook, just think of what you have studied or solved a question, and you'll be able to answer. But unfortunately, that is not taking you beyond 10,000. That is what you should understand. In a tough exam, when you answer 120 questions and come back, you will naturally feel very happy. You will feel, yeah, that I've done a pretty decent job. I've got 120 questions right. It was such a tough paper. 60% of the questions are there in my kitty. I should be getting a decent enough rank, but you're not getting a decent enough rank because others have outsmarted you. So this whole purpose of preparation is to be able to get an edge or to be able to be 1% better than your competitor. There is full throat, hard on competition here. That's what I said right from the beginning. So unless and until you are able to edge past your opponent, there is no point in you studying. You may have put a lot of hard work. Your mother may feel that you've studied really well. Your grandmother may be crying, but all that doesn't count for anything here. What counts is whether you've got the scores. And whether you've got the scores purely depends upon whether you've got the understanding. If your understanding is good, if your core idea is good, you will keep getting the scores. They are the winners, all the others are losers. And there is no shame in losing here because every time we have the next opportunity in 6 months' time, we obviously stand a better chance the next time. So we can always keep fighting, but we need to fight till we really reach where we want. Because it's not about whether you join in 2025 or 24 or 23. That is not what matters here. But finally, whether you join of course, the subject which you want, which is again very deceptive, but at least the place which can actually take your career forward. So this is the only way out. It is not about whether it's enough, but it's about how to edge ahead. And this is also a great opportunity. That's something which I think many of us forget. What I feel many of us forget is that this is also a great learning opportunity, right? When I joined for my first year PG, after having written the exam twice and feeling very bad about the fact that I lost a year, which is something which was very difficult for me to get into terms with, that I lost a year. I prepared and I wrote the exam 2 times. So it was like a kind of a confidence shattering kind of thing for me that I had to repeat for this exam again. But at the end of that, and after getting a seat, what I understood is I studied so much in the last 1 year, studied different subjects, studied medicine itself so many times, studied surgery, studied gynec. I was brimming with confidence when I reached the casualty, during my PG course. In the casualty, we see surgery as well as medicine, right? And some orthopedics as well. And then we kind of shift the case here, there, etc. But because we are in the same casualty, we do see a lot of patients. What I understood was my knowledge was really good. You can't stay at that level knowledge all the time. Naturally, it will go away. But you are really pumped with knowledge. I think if somebody has not prepared so well, then they wouldn't be knowing so many things. So even if you are not getting the ranks that you basically hope for at this point, which will definitely improve, your knowledge bar is going up, going up, going up, because all the teachers are putting in all the effort in the world and trying to teach you the best possible way, that they are also trying to give you the most important material. And without your knowledge, you're also studying so many things which are very, very important. Only thing is that you're not putting it into practice, but that obviously the time will come for that. But you're actually speaking knowledge bar wise going up. So that's a very, very positive thing. Okay. So on that note, we are winding up this discussion with these very, very powerful words that success is counted sweetest by those who never succeed. So I just hope that this is your first real counter with success. Or I would say your first real interface with success. This is going to be the exam which is going to bring success to your life. There may be few people who have already enjoyed a lot of success with respect to the NEET UG exam. So for them, this is not going to be too much of like kind of a success celebration or things. But there are lots of people who have not actually had that success in NEET UG, got into MBBS, not really made a mark for themselves, not really had a platform where they could prove themselves, and always have doubts about them, sit and cry sometime, and they always feel low many a time. So for those people, they really want themselves to be counted upon. No, they really want them to come on the big stage, and they also want them to at least be part of some interview with Rohan sir or Abbas sir. They want to actually be known, or at least their medicine to be known, or at least their hard work to be actually acknowledged at least. So for that, they are the people who count success the sweetest. And I hope through some good effort, dedicated hard work, and very diligent study, more than that, what I would say, to actually be very aggressive with respect to preparation and knowing that this is the way forward and studying very confidently, not looking out for shortcuts, understanding the core of every topic, you get there finally. Yeah. And when you get there, you get a digit or a 2 digit or a 3 digit rank. You really feel that, yeah, this is what I've been waiting for. And once you understand that that is success, and then that's the most happiest feeling. There is no bigger feeling. There is no more a happier feeling. So everyone will have their own benchmarks, and they'll be actually setting certain marks for them. So I never got any success in NEET PG. Though my rank was 524, I was not happy with that because I was a person who expected to get 1 or 2 or 5 or 10. But that exam was okay. I got 524, then I studied. But I really tasted success for the first time when I wrote these DM entrance exams, where I came first here, there, etc. So that is when I really enjoyed that success. Nothing special about it. It's just like 1 day, 2 days, or maybe maximum 3 or 4 days, and it goes away. But then you feel that yes, you have done the right preparation. Finally, it has taken you to where you have really wanted to be. So it is that success that we are talking about. So I hope that you also get to enjoy that. So keep going hard and keep, as I said, always be very aggressive with respect to preparation. Don't get bogged down. Please ensure that you're on the right track. And don't be just kind of going for this, that, etc. Fix up on something, keep studying that, keep doing the questions, and keep trying to keep investing time on understanding the core. And that is how I think I have discussed these questions. Whether I go to the core, know the core, then go to the next question. We don't have so much time also to go to the core. Go to the core, figure out the question, think about what we know about the core, and then just kind of keep going hard. So it's all about the next INI exam coming up in May. It's a matter of another 4 or 5 months or so. So give your best. Let's see how it goes. And this is more or less going to be the pattern. I think you may have a new set of questions, but the PYTs are more or less going to be the same. You have seen the PYTs now. With respect to medicine, you've seen the PYTs. This is where I think everything is going to be centered around. More or less, this is where I think everything is going to be centered around. The pituitary and adrenal part of your endocrine, from where you get a lot of questions. Then, of course, 1 or 2 questions on the glomerular diseases part in nephrology, questions on connective tissue disease in rheumatology. Then, of course, the pulse BP JVP section of cardiology, valvular heart disease in cardiology, heart failure and cardiomyopathies in cardiology, the spinal cord issues in neurology, and those things. So okay, the lymphomas, the leukemias, the hepatitis B virus and stuff. This is what they're going to ask you. So this is where we need to focus on. But that doesn't mean that we can just kind of mug up things and go from there. Our understanding, the more and more, the better our understanding is, the more and more we score. So on that note, signing off, and best wishes. And hopefully, for people who have not scored good ranks this time, the May exam is going to be a different experience altogether. So once again, thank you.